So in Parkinson disease, basically there was a degeneration of dopaminergic neurons in substantia nigra. And now there is a variant of Parkinson disease, which is called Shy-Drager syndrome or multi-system atrophy. So if a person present to you with feature of Parkinson disease, what are the features of Parkinson disease? The feature of Parkinson disease is rigidity, bradykinesia or slowness of movements, tremors, etc. Plus feature of Parkinsonism plus cerebellar ataxia plus autonomic dysfunction. So feature of Parkinsonism plus autonomic dysfunction such as urinary incontinence, postural hypotension, and erectile dysfunction. Autonomic nervous system includes, there are two parts of autonomic nervous system. One is sympathetic nervous system and one is parasympathetic nervous system. So in a patient with Parkinson disease, if its autonomic nervous system is also affected, he will develop autonomic dysfunction symptoms such as urinary incontinence, postural hypotension, and erectile dysfunction. So features of Parkinsonism plus autonomic dysfunction, then you will suspect Shy-Drager syndrome or multi-system atrophy. So if someone present to you with bradykinesia plus resting tremor plus rigidity plus ataxia, then it is Parkinson disease. And if there is sign and symptoms of autonomic dysfunction such as urinary incontinence, postural hypotension, and erectile dysfunction, then it will be Shy-Drager syndrome. The other name for Shy-Drager syndrome is multi-system atrophy. Now, if someone present to you with feature of Parkinsonism plus dementia plus visual hallucinations, remember that the only dementia in which there is visual hallucination is Lewy body dementia. So a person with feature of Parkinsonism plus dementia plus visual hallucination, remember that in Lewy body dementia or in dementia, the hallucinations are visual. While in psychotic disorders such as schizophrenia, the hallucinations will be audible hallucinations and not visual hallucinations. So dementia plus hallucination is Lewy body dementia, and the hallucination will be visual in case of dementia, while in case of psychotic disorder, the hallucination will be audible.
So in Shy-Drager syndrome, there is no hallucination.
No, in Shy-Drager syndrome, the diagnostic feature of Shy-Drager syndrome is Parkinsonism plus autonomic dysfunction.
Okay.
Autonomic dysfunction like urinary incontinence, postural hypotension, and erectile dysfunction.
Okay, thank you.
Parkinsonism with visual hallucination and dementia is Lewy body dementia. This is the only dementia in which there is hallucinations. There will be feature of dementia such as memory loss and decreased problem solving ability. Plus there can be sign of mild Parkinsonism such as rigidity, tremors, ataxia, and falls. Plus there will be visual hallucinations. For example, he will see humans or animals. Then it will be called as Lewy body dementia. The only dementia which has visual hallucination is Lewy body dementia. Lewy body dementia is a disease that is associated with deposition of abnormal proteins. These deposits are called Lewy bodies. That's why the name is Lewy body dementia. And the deposition of these proteins result in the signs and symptoms of dementia, mild Parkinsonism, and visual hallucination.
They
The
are
diagnosis of
deposited in
what?
the brain.
Yes, they are deposited in the different areas of the brain, such as the deposition of Lewy bodies in the substantia nigra will result in the sign and symptoms of mild Parkinsonism, and the deposition of Lewy bodies in other areas of brain, such as frontal lobe or temporal lobe, may result in the sign and symptoms of dementia.
Okay, thank you.
In occipital lobe, the deposition of this protein will result in visual hallucinations. The diagnosis of Lewy body dementia is made by MRI brain. Remember that most of the brain conditions are diagnosed best on MRI. There's only one condition in which we order a CT scan, and that is stroke to exclude the hemorrhage. In all other conditions, such as normal pressure hydrocephalus and different types of dementia, Alzheimer's disease, frontotemporal dementia, Lewy body dementia, Parkinson disease, all of them can be diagnosed best on MRI, because MRI is a good investigation to visualize the soft tissues like brain. So Parkinson features plus visual hallucinations plus dementia, it is Lewy body dementia. Parkinson features plus urinary incontinence plus postural hypotension. So urinary incontinence and postural hypotension are autonomic symptoms. So Parkinsonism with autonomic dysfunction, what is the diagnosis?
Scheidegger syndrome.
Yes, Scheidegger syndrome. Now, an old man with gait abnormalities plus dementia plus urinary incontinence. What is the diagnosis?
Normal pressure hydrocephalus.
Yes, normal pressure hydrocephalus. An old man making sexually inappropriate comments and hyperphagia and disengagement. What is the diagnosis?
Frontotemporal dementia.
Yes, frontotemporal dementia. A patient with a history of Parkinson disease present to you with acute psychosis or aggressive behavior, and he is punching everyone who is approaching him. What will be the most appropriate initial management of this patient? An elderly patient with a history of Parkinson disease who become aggressive and he is punching everyone who is approaching him.
Lorazepam.
But yes, lorazepam, lorazepam can be given IV if there is an IV line. It can also be given IM. So remember that haloperidol and other antipsychotics such as olanzapine and razapridone are contraindicated in patients with a history of dementia or Parkinson disease, because they can worsen the symptom of Parkinson disease and dementia. In all such kind of patients, the most appropriate initial management will be lorazepam. While in patient with no history of Parkinson or dementia, the initial drug for acute psychosis is haloperidol or olanzapine. Now, if a patient of Parkinson disease present to you with having some new symptoms and they ask you about what is the most likely cause of these new symptoms. If a patient of Parkinson disease present to you with extra movements, then you will select that the cause of the symptoms will be medication like levodopa. And if the patient of Parkinson disease present to you with bradykinesia or rigidity, even though he is on anti-Parkinson medication, but still there is bradykinesia and rigidity, then the most likely cause of these symptoms will be worsening of Parkinson disease. So if a patient with Parkinson disease present to you with extra movement, then you will select medication as the cause of these extra movements. And if there's bradykinesia or rigidity, then you will select worsening of the Parkinson the symptoms. Of dementia, there's a term which is called pseudodementia or depressive pseudodementia. How you can differentiate between dementia and depressive pseudodementia, as the name indicates.
Sorry, is also worsening of Parkinsonism, which is bradykinesia rigidity. It can be due to like the patient is not taking medication, or what could be the cause?
Yes, patient may not be taking the medication, but it will be mentioned in the history. And also, even though if the patient is taking medication, he may need increased doses for the improvement of the symptoms. So that's why even if a patient is having bradykinesia, even on anti-Parkinson medication, then you will choose a worsening of the Parkinson disease.
Okay, thank you.
Which is not responding to the treatment.
Okay, thank you.
So dementia and depressive pseudodementia is not a true dementia, but the sign and symptoms of depressive pseudodementia may mimic the dementia or true dementia. How you can differentiate between these two? There are three important points which can help you differentiate between these two. The first one is that in depressive pseudodementia, there will be a history of a major life event, such as a death of a loved one. So there will be history of depression in case of depressive pseudodementia. The second point which can help you differentiate between two is that the duration of the symptoms. For dementia, there will be long-term symptomatology. The duration of symptoms will be long, more than 6 months to 1 year, while in case of depressive pseudodementia, the duration of the symptoms will be short. So there will be short-term symptomatology. So the first one was history of depression or a major life event. The second one is duration of the symptoms. And the third and the most important point to differentiate between dementia and depressive pseudodementia is that the patient with dementia do not have an insight of their symptoms, while the patients with depressive pseudodementia will have an insight to their symptoms. So the patient with depressive pseudodementia will present to the hospital or to the clinic by themselves because they know that they are suffering from short-term memory loss and other symptoms. Because they have an insight to their disease, so they will present to the hospital by themselves, while the patient with dementia does not have an insight to his disease, so he will be brought to the hospital by the police or by his neighbors or by some family members. So this is the most important point to differentiate between dementia and depressive pseudodementia. That a patient with dementia will be presented by a family member or a neighbor or a policeman, while a patient with depressive pseudodementia will present to the hospital by himself. And also there will be history of a major life event, such as death of the loved one. So that's how you can differentiate between dementia and pseudodementia. Is it clear to everyone? Now let's do an example. A 70-year-old female present to the hospital complaining of forgetfulness for 3 months. So you can tell the diagnosis in the first line that a 70-year-old female present to the hospital. So she is presenting to the hospital by herself, complaining of forgetfulness for 3 months. So it is most likely pseudodementia because the patient is presenting to the hospital by herself, and the duration of the symptoms is short, which is 3 months. Now let's complete the example. Her husband died 4 months ago, so there's a history of major life event as well. For the last 3 months, she has been forgetful, more socially withdrawn. She is late in paying her bills. She contacts her children less frequently than usual. She had depression 20 years ago. So, what is the most likely diagnosis in this scenario? The diagnosis is most likely
The pseudodementia.
yes, pseudodementia. She is presenting to the hospital or on her own, relatively abrupt onset. The symptoms began after a major life event. Why not? It's a normal grief response because there are stages of normal grief response. What are the stages of normal grief response? The stage one of normal grief response that lasts for several days is denial, numbness, and disbelief. And the stage two of normal grief response that may persist up to 6 months includes sadness, weeping, waves of grief, etc. Poor sleep, guilt, blaming of others. So, whenever these signs and symptoms are present, then you will select normal grief response. In the above scenario, no such symptoms were present, so we selected depressive pseudodementia. Now, a 70-year-old female was found by the police wandering the streets in the middle of the night and brought to the emergency department. So, can you tell the diagnosis from this line? A 70-year-old female was found by the police wandering the streets in the middle of the night and brought to the emergency department. Is it dementia or pseudodementia?
Dementia.
Yes, it is dementia because the patient is brought to the hospital by the police. His neighbors told the doctors that he has been living alone after his wife died 1 year ago. See, there's a history of a major life event, but still the patient does not has an insight of his symptoms and he was brought to the hospital by the police. So it's most likely dementia.
So the
Yeah,
normal grief, sorry.
yes.
So the normal grief response, how long it should be? Like 3 months or 6 months, or is it like after 6 months it's uh it's not a grief response, it's like depression? Sorry, Doctor, your voice was cutting, so couldn't hear anything at all.